for virtual cardiac grand rounds today. I'm going to ask Lauren Baldessari to introduce our speaker for today. Thank you.
Hi, good morning, everyone. Good morning, Jonathan. It's my pleasure and an honor to introduce Dr. Jonathon Leipsic for our Grand Round speaker today. We're really in for a treat. He's an amazing speaker. He comes to us, he's a professor of radiology and cardiology with the University of British Columbia. He's chairman of the Department of Radiology for Providence Healthcare in Vancouver and vice chairman of research for the Department of Radiology as well. He is a leader in the field of cardiopulmonary imaging. He has over 500 peer-reviewed manuscripts in press, and he speaks internationally on many topics, and one of which his specialty is cardiac CT, and specifically coronary CTA, as well as CT for the use of structural valvular disease assessment. And he's also just a really nice guy and a great mentor in the field. And he also was recent past president of the Society of Cardiovascular CT 2015-2016. So it's really my pleasure to introduce Jonathon this morning. Thanks so much. And we wish we could have had you in person, but hopefully some other time in the future.
Yeah, no, it's a real honor and a privilege. I would share my video. Maybe I'll share it at the end of the talk because no one should see me at this hour. It's a real privilege and honor to be speaking with you this morning, and I hope you'll find the discussion of interest. I'm going to try and take you on essentially a tour of cardiac CT for stable chest pain. And over the last 15 years, we've seen a deluge of data and information that's helped support its clinical use for patients with suspected but not yet confirmed coronary disease. We'll talk about a little bit about the implications of the Ischemia trial and our recent COVID pandemic, and where we're potentially going. So again, grateful for the opportunity. So before I get going, I'd like to share with you that I do have some disclosures that are relevant to the talk. Most of my disclosures reflect the core lab work that I do, and I run a core lab that supports the structural heart disease trials for Abbott, Medtronic, Edwards, but I take no personal compensation for that. I do give advice to HeartFlow for the last 2 to 3 years, 3 years, I guess. Before that, I did simply research with them, but that's obviously salient to this talk. And I also have a research grant from GE Healthcare, who obviously make CT. So I'm going to share with you a clinical case. This is a case that's a fixture of my talks because it's just a fairly classic clinical example of what we see in Vancouver. Before the COVID pandemic, we were using a small footprint dedicated cardiac CT, purpose-built for cardiac CT, and we do about 25 to 30 coronary CT angiograms in a 9-hour shift, and we'll go see the patients, or my fellows will, and ask them their questions with regards to angina typicality, or we'll have them fill out a form and a questionnaire. And so this patient presents having had chest pain 3 times, once occurring while he was arguing with his wife. It also had intermittently awoken him from sleep. And then it may have occurred once while riding a bike uphill, but when you talk to him, he didn't stop biking. I mean, he wasn't going to win the Tour de France by any means, but he continued biking and the pain went away. So he presented to my friend, who's a clinical internist who sees patients with suspected heart disease and manages such patients in the Canadian system. He's dyslipidemic and hypertensive. His family doc had him on some medical therapy. And my friend sees him and sees this 64-year-old white male who's mildly obese, who had atypical chest pain on 3 occasions. It's somewhat exertional, but on the other hand, not classic. And so, as is often the case, and historically, my clinical colleague has really faced with the question of what test to order. And I would argue that the test that's ordered should really be focused on helping answer the clinical question at hand. And so to me, the clinical question at hand in this case, I think, is not, what is the myocardial blood flow look like in the left ventricle? It's not what is the diastology of the left ventricle. It's not is there valvular disease. It's none of those things. All of those are important questions, but at least in my humble opinion, I think the question that the patient is asking is, do I or do I not have coronary artery disease, and how extensive is it, and is it going to affect the quality or length of my life, and how are you going to treat me? And so when you look at the traditional workup and management of such a patient, you could see that it's incredibly challenging to evaluate such patients. And I would just quickly highlight before we look at the testing that's traditionally ordered and recommended. I'll highlight this pretest likelihood calculator that was updated and provided to us in the chronic ischemic coronary syndrome, guidelines, as called by the Europeans, published last year in European Heart Journal. And what you could see here is that if we compare it to traditional Diamond and Forrester pretest risk calculator, we could see that a 64-year-old white male with atypical pain has a pretest likelihood of 26% of having anatomical coronary disease. And this is really important because if you look at the historical pretest likelihood calculators, it would suggest that his pretest likelihood is probably around 60 or 65%. So the pretest likelihood calculators have been iterated on the basis of really a wealth of CT data coming to us from the Confirm registry, which we contributed to, and some work that was published by Dan Berman and Victor Chang back in 2011, as well as many other data sets, including the PROMISE data set, that highlights that the population that we're serving with cardiac CT that are coming into these clinics with symptoms suggestive of possible or even probable angina pectoris, the pretest likelihood of these patients is much lower than what's historically seen. And this shifting of the pretest likelihood, I think, has made it even more difficult for my clinical colleagues that are seeing these patients to make appropriate test decisions, because as you can appreciate, a 26% pretest likelihood is far too high to simply dismiss. On the other hand, it's far too low to simply send to the cath lab. So it's a challenging population to serve, particularly given the historical workup and management. This slide, courtesy of an old friend of both Lauren and mine, Jim Min, he lent this to me many years ago, and unfortunately, the slide is still relevant now because the stable ischemic heart guidelines, of course, in the U.S. have not been iterated since 2012. I'm very hopeful that we'll have new guidelines this year because you can appreciate that the traditional workup and management for patients like the patient I highlighted, I think has fundamental limitations when it comes to answering the question, do I or do I not have coronary artery disease? And so if you don't agree that that's a question being asked, then I think that you could argue towards some of these testing. If you think that the patient, really the question that you want to know is, is there exercise-induced wall motion abnormality, then obviously stress echo is your test. But I think ultimately the clinician wants to know, does the patient have atherosclerosis and how severe is it? When we look at the traditional pathway, it involves, of course, the adjudication of symptoms. And I would argue with you that the traditional adjudication of symptoms is obviously quite limited in the modern population. Here's the Netter description of classical angina pectoris. And you can appreciate that if you're living in Vancouver where we don't have snowstorms and half of our patients are women and many of our patients are non-Caucasian, that relying on the classical symptoms of an older white male coming out of a restaurant into a snowstorm in Boston may not be that applicable. And so to imagine that the only way that you can have coronary artery disease related symptoms is if your symptoms are exactly like this individual, I think is both naive and frankly sex, gender, ethnically biased, and I think has led to under-testing certain populations and probably under-treatment. Traditional stress tests, I think, obviously play an important role in cardiology and will continue to play an important role. But I don't think they're surrogates. These are tests that were not really meant to adjudicate whether or not there's an epicardial stenosis, and certainly are not sensitive for the detection of atherosclerosis, which is, I think, so essential in determining medical management up front, long before we make decisions around possible revascularization or anti-anginal medical therapy. And then, of course, invasive angiography. When we look at well, the pathway is done, what we could see is that it frankly has been limited in the ability to adjudicate anatomical coronary disease. On the right is a classic chart or graph from Manesh Patel and Pam Douglas's work from 10 years ago in the New England Journal from the NCDR registry, showing that 2/3 of patients that went to the cath lab in the US were not found to have actionable coronary artery disease. They did not have anatomical stenosis. And of course, this wasn't the interventionalist's fault. It's not her fault if I send her a patient with an equivocal or positive stress test and chest pain and she doesn't find anatomical disease. That's a failure of our workup and management of these patients. Similarly, for my friend Dan Berman down at Cedars, looking at his nuclear SPECT lab, you could see they found 101 patients with anatomically severe left main disease that had undergone SPECT testing before. And what you could appreciate is that 44% of those patients with left main disease had normal or mildly abnormal stress tests. So, importantly, the message to me from these data is that if you have a normal or mildly abnormal stress test, the only way you can be confident that the patient doesn't have left main disease, or the only reason you can be reasonably confident, is because the burden of left main disease is simply quite low, not because you can be confident that the test actually helps discriminate the presence of left main disease amongst those patients that have it, because I just don't think, at least SPECT at Cedars-Sinai was very effective in doing so, and I think we see that in clinical practice. So then why coronary CTA? I think coronary CTA, because again, not because it's perfect test, but if the question is, do they or do they not have stenosis in their epicardial coronary arteries? Do they have atherosclerosis? I think that the most direct way of answering that question is to actually look at the coronary arteries. And we see data, this is really old data now. These are studies done in 2008 on historic CT platforms that would suggest that the diagnostic performance of cardiac CT is superior to other tests. It's not perfect. It doesn't have perfect correlation on a per segment basis with invasive angiography. Of course, invasive angiography doesn't have perfect correlation with the interpretation of invasive angiography even. But what we do know is that it has incredibly high negative predictive value for ruling out disease and a fairly high positive predictive value and specificity. What we also know is that coronary CTA from those data that I showed you has become increasingly safe over the last decade. There was a study called the Protection 1 study, which was published in 2009 in JAMA, where Jörg Hausleiter from Munich showed us across a registry from across the globe that the dose from cardiac CT was too high. On the other hand, in 2018, with data that was 10 years on from the Protection 1 study, what he showed us was that through a large registry, which we contributed, that the dose from cardiac CT across many, many sites, across 5,000 patients, was significantly lower than it was a decade earlier, approximately 80% lower, with a median effective radiation dose between 2.5 and 5 millisieverts, depending on the conversion factor. And I think this highlights to me that, of course, by no means am I suggesting that we should be screening patients or doing this on patients without obviously clinical indication. But if you have a patient with symptoms suggestive of possible or probable angina pectoris, this is a very accurate, effective tool that has a very high negative predictive value that can be done in a safe fashion. So the third question that I think many patients ask beyond, do I have coronary disease? Can you test me in a safe fashion? Is what does this mean to me and my family? And so if we want to look at prognosis, we could give a whole hour on prognosis, but I clearly won't. But I'm just going to share with you two slides from very important studies from the US in the last number of years. This data comes to us from Udo Hoffman down the road in Boston, but it's a sub-analysis of the PROMISE trial. The PROMISE trial, of course, was 10,000 Americans randomized between anatomical testing with CT and functional testing with SPECT. What you can see here are two of the key elements or incremental benefits of CT. When you look at the x-axis, it's time, and the y-axis is percentage with events. If we look at the two lowest Kaplan-Meier curves for the anatomical testing, or CT, you could see that the lowest curve is those without atherosclerosis, and the 3-year event rate is below 1%. That's under half that of those with a negative SPECT study. In addition, what you can see nicely is that those with mild atherosclerosis but no stenosis had a 3-fold higher event rate than those without atherosclerosis. This is exactly the same hazards ratio as those in the confirm registry, which we published many, many times. And people simply said, well, it's confirmation bias, and they questioned our data, but it was reproduced in this randomized trial with almost the exact same risk, threefold higher risk amongst those with atherosclerosis, but no stenosis. On the other hand, if we look at those with a mildly abnormal SPECT test and a normal SPECT test, if you simply can't tell them apart because you don't know who has or doesn't have atherosclerosis. So when you're confronted in your clinic with two patients, one with a mildly abnormal and one with a normal SPECT test, you simply have to revert back to their baseline cardiovascular risk factors with regards to guide their medical management, because you have absolutely no idea who does or doesn't have disease, and their event rates are very similar. So you certainly can't up titrate or down titrate medical therapy. Similarly, if we look at those with a severely abnormal CT, the relative risk is tenfold related to the very low risk of those without disease and the modest likelihood of a extreme false positive. In other words, if we call triple vessel disease, maybe at cath it's two vessel disease, maybe even it's one vessel disease, but it would be considered a quality issue if we call triple vessel severe anatomical disease and they didn't find a single stenosis at the time of cath. On the other hand, the relative risk of a severely abnormal stress test is muted. It's only fourfold, partly driven by the higher event rate of those with a normal SPECT, but in addition, the false positive rates of severely abnormal SPECT tests. As we saw in the Ischemia trial, we provided some of the core lab CT support along with Jim and Matt Budoff. And what did we find? Amongst those with severely abnormal nuclear stress tests, or stress tests in general, 16 to 18% of those patients did not have a stenosis greater than 50%. So I think that the ability to discriminate risk is much more profound with CT than it is with traditional functional testing. Not to mention the warranty period of those without atherosclerosis is much longer than the traditional warranty period of a negative stress test. Let's look at data shared with by David Marin. This is an analysis done by Harmony Reynolds from NYU and presented at the virtual ACC about a month, whenever that was, a month and a half ago. And what did David show us? If we look at the relationship between anatomy and mortality and the severity of the stress test abnormality and mortality, what you could see here is that the degree of ischemia, if we look at this is the none or mild ischemia, and you look at the risk associated with those with moderate or severely abnormal stress tests, the percentage four-year event rate is actually lower. And there's no relationship between the severity of the stress test and risk with regards to all-cause mortality as it relates to the extent and severity of anatomical coronary disease was strongly significant, suggesting that, again, anatomy is a strong predictor of risk. Of course, we've known that going back to Courage as it related to John Mancini's work related to invasive anatomical data, that the anatomy trumped the functional abnormalities from Courage as well. Beyond stenosis and the presence or absence of atherosclerosis, of course, there's growing evidence that that CT can provide us a non-invasive sampling, essentially, or characterization of patient-specific atherosclerosis. Again, that's going to go beyond the scope of the talk, but we know that the extent, the severity, and the pattern of atherosclerosis, so whether or not it's low density, adaptively or positively remodeled, if there's napkin ring sign, all of these things can help us understand patient-specific risk, as well as understand the relationship between atherosclerosis and risk. And I think eventually, particularly with AI and machine learning algorithms, we will be able to actually quantify plaque in a reproducible way, in a fashion that will potentially help guide medical management and understand the effectiveness of therapies as we treat them with anti-lipid or lipid management medications and anti-atherosclerotic treatment strategies. And before I transition to physiology, I would like to end with this question that patients ask before we even begin to address the question of whether or not to revascularize, and that is, is this information that I've shared with you, is it really helpful in guiding medical management? And what we've seen from Scott Hart and many other registries is that coronary CT does appear to guide clinical decision-making in a fashion that improves outcomes. Now, here's the Scott Hart 5-year data presented by David Newby at the ESC in 2018 in Munich and published in the New England Journal. What we could see here is that the relationship between, that those patients that were randomized, of the 4,000 Scots that were randomized to CT strategy as compared to traditional care, is that those that were randomized to the CT strategy experienced a 40% lower myocardial infarction and cardiovascular death rate than those that were randomized to traditional care. Now, over time, many people question how this was possible, that the relative use of the differences in the use of statin therapy was only 35% between the two groups. So how is it that they could realize a treatment effect of 40%? And I think what was missed by many is that it's not just that there was a shift or that the total usage of statins was different by 35%. It was actually which patients were being treated with statins and how that was determined. Of course, in the traditional care arm, the determination for the use of statin therapy was based on the risk of the disease. Whereas what you could see here from David Newby published in JACC this year is that the use of statins on the bottom here was determined not based on the risk of disease in the CT cohort, but based on the presence or absence of disease, which I think is much more powerful. X-axis is the assigned risk score. Y-axis is the percentage of patients on statins. Gray is those without atherosclerosis. Purple, mild atherosclerosis, but no stenosis. Orange, stenosis. You could see that if you had the low risk of having an event or of having a coronary artery disease according to the assigned risk score, but you actually had the disease, the cardiologist in Scotland said, you may not have the risk of the disease, but you have the disease, I'm going to treat you. On the other hand, if they had a high risk of the disease, but they had no disease, and they're 70 years old, the likelihood that they left on a statin was relatively low because, of course, the cardiologist said, I really don't know what I'm treating. So I think the opportunity to actually titrate medical therapy rather than on the basis of the risk of the disease, but instead based on the presence or absence of atherosclerosis is incredibly powerful. It's powerful for the patient with regards to adherence, and it's certainly powerful, I believe, with regards to helping optimize medical therapy and preventing plaque progression and ultimately preventing incident myocardial infarction. So all of this data, I think, led to the ESC to update their guidance last year, as we all know, published in the European Heart Journal, providing the first multi-society guidance for the use of coronary CT as a first-line test, class 1 indication, recommended for all those as a first-line test, except for those that cannot undergo coronary CT or those deemed to be have high pretest likelihood. And importantly, if we reflect back on their pretest likelihood calculator, there were very few patients who had a pretest likelihood of greater than 50%. So I would argue that the Europeans are strongly supportive of the concept of a CT first strategy in at least a good number of the patients that we see. Now, many people will ask me, well, this is all great, but the ESC guidance came out, of course, before the Ischemia trial. What does the Ischemia trial mean for the use of coronary CT? And obviously, as you probably can tell, I enjoy coronary CT, and I believe in it as a test, as a first-line strategy. But I really do believe, as someone who is embedded in the cardiac CT core lab, is that I think ischemia further supports the concept of a CT first strategy. We know the trial, I'm assuming, I don't have time to go into it deeply, but we know a very large trial with a large number of patients randomized in the setting of moderate to severely abnormal stress tests, importantly excluding those with severe angina and those with reduced ejection fraction. CT ruled out left main disease and confirmed the presence of anatomical disease. What we found was that CT identified 5% of patients with left main disease and also identified 16 to 20% of patients that did not have coronary disease that were excluded from randomization. And then they were randomized to either a cath strategy or a conservative strategy. What you can importantly identify, and I think many people ignore, is that 30% of patients that were in the conservative arm crossed over. So those patients actually were intervened upon. So the difference in intervention was really upfront. There was a more profound difference, but over time it sort of waned. In addition, what were the take-home messages? Well, we saw that there was no significant difference between a conservative versus an intervention, upfront intervention strategy when it came to the composite endpoint of CV death, MI, resuscitated arrest, or hospitalization for unstable angina. But there was a significant difference in the quality of life, which was better amongst those that were revascularized with less angina, amongst those with revascularization, assuming they actually had frequent angina. We know that the quality of life benefits were obviously greatest for those that had frequent and significant angina. In addition, while there was no difference in MI, I think what's interesting for us to all look at over time is that those patients that underwent revascularization had fewer spontaneous myocardial infarction, which was counterbalanced with the procedural troponin leaks that were seen with those that were intervened upon. So the net effect was no difference in total MI, but I think nonetheless interesting and important for us to look at. So what are my takeaways as it relates to CT? I think stress testing was unable to confidently identify coronary artery disease. And I think that that's an important thing to know. If we're going to take a conservative approach, I think it's important to know what you're actually treating. If you want to be conservative about a cancer, it's important that you actually diagnose it. I think that being conservative before you actually know the extent and severity of coronary disease is probably not appropriate. So I think CT is helpful to identify that. In addition, I don't think any of us would really want to be conservative with severe left main disease, which was identified in 5% of patients. And as I showed you from David Marin's presentation, is that CT anatomical severity informed prognosis, which I think remains a very important element in testing before guiding management. Before we move on to physiology, I would also highlight, some of the guidance that we're getting from COVID. I mean, we could have a whole talk on COVID, but I think that this guidance that came out April 21st from the European Society, and I know I'm working with many on the JACC Imaging editorial board on at least a position paper from that journal, that the ESC guidance was, I think, the strongest guidance that would suggest as we're coexisting with this virus, whether in the acute phase or in the recovery, or I call it the sort of convalescence or coexistence phase, that cardiac CT really should be considered as the first-line test for patients with possible but not yet confirmed coronary disease, because it's obviously very fast, very direct, doesn't involve the need for exercise, and it can be done in an outpatient setting. The patients can be discharged quickly, usually in my hospital, a turnaround time of a total of 1 hour. In addition, we're seeing a real increased utilization for cardiac CT, even in patients with troponin elevation. Obviously, we've, I'm sure, read a lot about the STEMI phenocopies seen with COVID-related heart disease. I think building on the recent verdict trial, which showed that use of CT to help guide the urgency and the need for invasive angiography in the setting of non-ST segmented elevation MI has been very powerful and important data. And I think it's become increasingly important as we coexist with COVID, really trying to limit PPE use and making sure that patients go to the cath lab are actually going to derive a benefit from going to the cath lab. And so at least in my institution, and I know in many others, people are using CTA not only for low risk chest pain, but even those with NSTEMI and low GRACE scores. So finally, for the next 15 or so minutes, maybe I'd like to address the concept of using CT to actually guide revascularization. And so, this has been a real limitation of cardiac CT over the years, is that it really could help inform the diagnosis and prognosis and even guide medical management. But if I identified an LAD stenosis and I said it was 72.65%, which obviously I can't, and they took the patient to the cath lab and they found exactly the same anatomical stenosis, what we know is that interventionalists could not actually appropriately revascularize this lesion without documenting physiological significance or functional consequences, either non-invasively or invasively. And the reason that is, of course, we know that the totality of randomized data to date does not support revascularization on invasive anatomy alone. We know that the gold standard for guiding revascularization has been invasive physiology over the last number of years, really since the FAME-1 data, which came out in 2009, which disappointingly came out after the initiation of or or at the time of the initiation of the Ischemia trial, which is why invasive physiology was not fundamentally embedded in the Ischemia trial. But what we could see here is the 5-year data from the FAME2 trial. These two Kaplan-Meier curves look at urgent revasc and MI. X-axis is time, y-axis is percentage with events. These are patients with positive physiology, FFR below 0.80, and the red is those that were then treated just with medicine alone, the blue treated with revascularization. And you can see that amongst those with significantly abnormal lesion-specific physiology, that there's an apparent benefit in revascularization, certainly when it comes to urgent unplanned revascularization, and even a clear signal for MI in this one trial alone. In addition, this is data from the Veteran Affairs Network. Senior author was Bill Fearon from Stanford. What you could see here, and this was published this year, is that the use of physiology is increasing, certainly amongst those that are undergoing PCI. And all comers, keep in mind 60% of patients don't even have moderate coronary disease or moderate to severe coronary disease at the time of cath. So the use of physiology is increasing. But what's really interesting in this large registry is that those patients that were revascularized on the basis of physiology in red had a significantly lower mortality out to 1 year than those who were revascularized on the basis of angiography. Now, obviously, it's observational. This is non-randomized data. There's probably a number of variables that cannot be accounted for or adjusted for. But nonetheless, I think that the data is consistent both from registries across the globe as well as the randomized trials that physiology adds value with regards to guiding revascularization. So we know that anatomy and physiology are not the same. So we can't simply take our CT data and guess or assume that a more severe lesion is positive and a less severe lesion is not. These are data from a registry that we helped put together called the Advance Registry, which looks at non-invasive physiology. But you all know, I'm sure full well, that I could share with you the exact same slide from a whole host of invasive studies that show that there's a historically inconsistent relationship between anatomy and physiology. That sure, a severe lesion is more likely to be physiologically significant than a non-severe lesion, but it's not absolute. That 70 to 90% stenosis are physiologically negative, 1 in 5 at least, maybe 1 in 4, and 40 to 50% lesions are positive in 15 to 20% of cases as well. So what do we need if we're going to actually use or extract physiology from a CT? Well, I think one of the options is to use non-invasive FFRct, in which we take a CT scan in Vancouver or in Connecticut. And what we do is we take that data and it's uploaded and anatomically modeled and then accounting for a number of form-function relationships. Followed by the application of computational fluid dynamics and the computed expected effect of the administration of adenosine, and a 3-dimensional physiological model is generated that allows us to extract calculated pressure measurements anywhere in the epicardial coronary system above 1.8 millimeters. Now, clearly, I don't have time to go through all of this, and I'm not an engineer, but there is a wealth of data that supports the concept of extracting physiology from an anatomical data set. We know that this is done for many years in the aerospace industry, and one of the things that really limited the ability to do it in the coronaries is that we never had a robust anatomical patient-specific model. Well, now, of course, we do with coronary CT. With that, there's a number of form-function relationships that we're aware of that help us understand a model. So, for example, the root of the aorta helps define inlet flow volume. So big capacious sinuses are relevant. We also know that coronaries that are large have lower microcirculatory resistance. We know that the coronaries that respond to nitrates are, better vascular health. We know that coronaries adapt to maintain a homeostatic level of shear stress, and so that's why people who exercise a lot generally have better nitrate response and larger coronaries. Similarly, if we have an athlete with thick left ventricular myocardium, that individual has more resting flow to meet demand unless they have angina at rest. We also know that blood is a Newtonian fluid, so that all the laws that govern Newtonian fluids will govern blood. And then hyperemia can be modeled, and this is where FFRct is a conservative calculation. because we do know there are some patients in which our interventional colleagues do not achieve hyperemia, either for technical reasons or because their microcirculation doesn't allow for adenosine to paralyze it to drive that hyperemic response. So the hyperemia that's modeled will result in an FFRct value that is lower than some patients where hyperemia is not achievable. Now, what is the data? If we look at invasive FFR as the gold standard, this is data from the Pacific trial published by Paul Knappen back in 2019. He took 208 patients in Amsterdam and did 3-vessel FFR, oxygen label water PET, CTA, and SPECT. The lower 3 tests were read by core labs, thereby, I think, at least inflating the diagnostic performance. We're part of the CT core lab. Jimin did the reads as well. So there were 2 readers and a third for adjudication. And you could see that FFRct exhibited the highest diagnostic performance for the discrimination of invasive physiology, which again doesn't surprise me. These other tests are not really meant to adjudicate lesion-specific physiology. These are tests that look at a number of other things. But FFRct is purposefully designed strictly for that question at hand. Not for the evaluation of atherosclerosis, not for the evaluation of relative blood flow but to the myocardium, but actually to calculate pressure across specific lesions. Now, like anything, image quality matters, and it matters when it comes to anatomical CT. It certainly matters when it comes to physiology. When we do images like on the far left here, my anatomical accuracy compared to cath is certainly over 90% based on the our routine audits. On the other hand, when we have images like this, we usually say we can't exclude anatomical disease, and HeartFlow will simply reject this case. I think these are the cases that are almost the greatest risk, because these are cases that my colleagues will read anatomically, and our accuracy is probably only in the mid-70s. Similarly, HeartFlow, when they do these analyses, although they don't, their label just simply says the accuracy is 88% or whatever, I believe it's 88 or 87%, but clearly it's a blended accuracy across these types of images. And I think it's on us to make sure that the image quality is as good as possible, because the better the image quality, the better our accuracy anatomically, and the better the physiological extraction as well. We looked at the relationship between heart rate and rejection, or all of these measures of image quality and rejection being a surrogate for image quality. And you can see amongst 13,000 cases submitted for FFRct, if the heart rate was above 60, the likelihood of rejection went up significantly. So it's on us to actually reduce the heart rate well, so that we can actually evaluate the coronary arteries anatomically and use physiology when we need to. We also pay a lot of attention to detail as it relates to nitroglycerin administration. I believe in 2 sprays of nitroglycerin where possible. I know using spray for CT is a challenge in the US. I know there's a powder that some people use, but I think the bioavailability of the spray is better. And I also believe in obviously waiting the 5 minutes, but using 2 sprays where possible. This is just an in-person comparison that we did in a small data set at our site. And you could see that following the administration of 0.8 milligrams of nitroglycerin, that the coronary volume was significantly higher than following the administration of 0.4 milligrams of nitroglycerin. And that difference is important, I think, as it relates to not only physiological modeling, but also even just extraction of anatomy and anatomical assessment. This is a slide lent to me by Stefan Achenbach, which is, I think, really important. At the ACC last year, not this year, but the last in-person one, he gave a futuristic talk on the future of coronary CT, and the room was full, and everyone thought, what is he going to talk about, plaque or AI? And at the end of the day, all he said was image quality and interpretation skills are going to be essential for cardiac CT to actually have a meaningful future. And that was really important. At the end of the day, if we don't do good cardiac CT and if we don't read it properly, none of the rest of this data that I've shared with you will matter. And so he really highlighted that consistently across all scanner platforms, that lower heart rates drive significant improvements in diagnostic performance. So how do we, if we get FFRct, how do we interpret it? Well, we interpret it by answering important questions, by extracting physiology purposely to answer the question at hand. So here's an anatomical physiological model, and you can see the patient has LAD stenosis. And so I think if we want to answer the question, should this patient go to the cath lab for consideration of PCI with the hopes that it will actually improve quality of life and angina and potentially reduce MI as compared to medicine alone? The key value to answer that is the value distal to the stenosis and whether or not there's a translesional pressure loss of greater than 0.1. In this case, you could see the value of 0.83 and a translesional gradient of only 0.07. This is a case where we would say no real reason to go to the cath lab. The lesion-specific physiology is in the normal range and there's no significant translesional pressure loss. On the other hand, the value of 0.70, people will say, is that a false positive? And I would argue that that's not a false positive. It's just that it's telling us something else. It shouldn't be used to help guide cath. What it should be used for is to help us understand patient-specific vascular health and overall atherosclerotic burden. What we see is that patients that have low nadir FFR values invasively are at higher risk. We've learned that from the 3-vessel Friends study and other studies. Similarly for FFRct, if I took a professional NFL player and did a coronary CT angiogram, his distal nadir LAD value would not be 0.70. So this patient is not well. It's just that that 0.70 doesn't necessarily mean that the patient should go to the cath lab, but aggressive medical therapy seems appropriate. Similarly here, this is a patient now almost 2 years post FFRct in our site. You can see a big right coronary, not surprisingly. Big right coronary, more flow. As a result, the flow is increased, the resistance is increased in the distal right coronary. You can see that there's progressive pressure loss in the distal right, but no focal translesional gradient, nothing to treat. This patient has diffuse atherosclerosis and needs medical therapy. So how do we interpret these? Well, we use it not just in a binary fashion. If the FFRct is negative, we have growing evidence, not only at our site, but through a number of registries that these patients can be safely deferred from cath. On the other hand, if they have an FFRct below 0.75 distal to a stenosis, those patients should be considered for cath. And if it's in the gray zone, it really depends on the location, the translesional gradient, and the so-called plaque features that help us determine whether or not to upfront medically treat or send the patient to the cath lab, and then obviously in addition to the symptom status and symptom severity. How has it impacted clinical decision-making? Well, we've seen from Manesh Patel's presentation a year ago from the Advanced Registry, the one-year outcomes data, we could see that those patients that had negative FFRct had improved outcomes when it came to cardiovascular death or MI, and those with abnormal FFRct were much more likely to be revascularized, not surprisingly. Those with a negative FFRct, only 6.5% were revascularized at a year, and most of that happened early because of traditional, perhaps, treatment decision-making. But if they were not revascularized within 90 days, the likelihood that they needed to be revascularized owing to ongoing angina was very low, less than 1% between 91 and 365 days. As far as outcomes data, there's growing outcomes data. Some data from our site, as you could see here. We have data from Denmark in the one-year advanced registry. So there's now about 6,000 patients that have been followed 1 to 5 years that shows, I think the real strength is that regardless of anatomical severity, in a fashion similar to invasive physiology, if you have a negative FFRct, those patients can almost certainly be safely deferred from cath. Importantly, FFRct is not just a binary tool. We know that invasive physiology is not either. I mean, in a randomized trial, you have to use a cut point to randomize patients, but in clinical practice, we know from Niels Johnson and many others that the lower the FFR, the higher the risk. The lower the FFR, potentially, the greater the benefit of revascularization. Well, we've seen something similar with FFRct. These are data on the right from the 5-year outcome data from NXT, from Abdul Idahid, who's with me now in Vancouver for a year, but is from Melbourne. And what you can see is that the lower the FFRct value, the higher the risk. Same in the advanced registry. So, you know, an FFRct of 0.6 is obviously very different than an FFRct of 0.79, which is not very different from an FFRct of 0.81. People will often ask me, when do I use it? And I always say I practice medicine. I don't use it for all 70 to 90% lesions. I don't use it for all 40% lesions, but I do use it for some of both. Why do I use it for 70 to 90% lesions? Because people will tell me, aren't those patients just going to the cath lab? Well, I think the reason I use it is that 1 in 4 patients will still have negative physiology, which saves me and the patient the cath. But in addition, 2/3 of the patients will have severely abnormal physiology, which is, I think, quite important to my interventional colleagues, because I'm now no longer sending them a positive anatomical study, but rather sending them an anatomical study, as well as a study that also provides important physiological information that I think can allow our interventionalists to not only then cath the patient, but then to revascularize the patient, assuming the anatomy is concordant with the CT on the basis of the non-invasive anatomy and physiology. Now, everything I've shown you to date is observational. There is a randomized trial that will be presented later this year from Nick Curzon. This is from the UK, 1,400 patients that completed enrolling a year ago. In addition, as you probably are aware, I believe you're involved in this trial, the PRECISE trial, which is led by Pam Douglas, which is an important randomized trial comparing a precision arm CT/FFRct versus traditional care. But we'll also have embedded within it a no testing randomized subarm, looking at those with the lowest risk according to the PROMIS risk score. So I think this is a really important trial, not only to answer the question of whether or not CT/FFRct is superior to traditional testing, but also to help us better identify those patients that don't need testing, because there's no doubt, in my opinion, what we need to be doing is not testing those that aren't going to derive any benefit, and using the right test for those that will derive benefit. My final 5 minutes are really going to be closing on what I think is the future of cardiac CT, and that is to help plan coronary intervention. I think our interventional colleagues need our help. I think we've never been able to help them because we've never had a non-invasive anatomical tool that could really allow an interventionalist to go to the cath lab with a plan. And so I think what we've seen over the years is that of course, the role of the heart team as it relates to complex coronary disease has really faded into the background. We've sort of provided some test likelihood of coronary disease and told our interventionalists, good luck, find what you find and treat what you want to treat in an ad hoc fashion. And yet, I'm sure at Yale and certainly in Vancouver, my colleagues would not go to the cath lab and do a TAVR without a non-invasive evaluation of the annulus. And yet we've seen over the years that our interventional colleagues get patients coming all the time on the basis of our historic pathway. Many times they're found to have no coronary disease, and then other times they're found to have severe coronary disease. And I would argue that this is an incredibly challenging thing to try to manage, particularly based on a historic reliance on luminography. Why do I think it's a problem? Well, I'm sure we're going to see this from the Ischemia trial. Incomplete revascularization is common. It occurred in the Syntax trial 30% of the time, and some other trials up to 50% of the time. And while I know some patients cannot be completely revascularized just because of safety concerns, I think that the incomplete revascularization rates are far, far too high. And we know that those patients that are incompletely revascularized are at heightened risk for downstream MI and downstream events. So, okay, hopefully this will play. Yeah, this will play. I guess it's what we see here is a nice Colette, and he's showing me how we can potentially use CT to help guide fluoroscopic angle planning to really help inform the interventional procedure. The concept there is that instead of going to the cath lab with a predetermined fluoroscopic angle that the interventionalist uses for all patients, my anatomy is not the same as all patients. My anatomy is my anatomy. We know this from TAVR. Don't use the same fluoroscopic angle to do a TAVR for me as you do for every other patient. And you can see in this case, here's the traditional fluoroscopic working angle. It looks like a 3.6 centimeter lesion. Here's the angle that was suggested on the base of the CT. And you could see that had the interventionalist placed a 3.6 centimeter stent, they would have left over 1 centimeter of untreated LAD. This is clearly not in the interventionalist's best interest, nor the patient's. How about this? How about trying to avoid unpleasant surprises? I would argue that you shouldn't diagnose critical left main disease with a catheter in the left main. That is not the time to be surprised. I think what we can do with CT is we can help inform cath by also helping not only provide the fluoroscopic angle, but making sure that if you're going to take a patient to the cath lab with left main disease, that you're aware that you are, that it's a discussion. Should we cath this patient? Should we be ready to stent this patient? Should we be cathing them just selectively? And then with a plan to quickly refer the patient for surgical revascularization. And then finally, what about anatomy and physiology? We know from Carlos Collet and Professor Soroy's from the Syntax 2 trial that using non-invasive anatomy and non-invasive physiology can help provide a functional syntax score that correlates quite well with the invasive gold standard of anatomy and invasive physiology. The concept here being that you can actually provide a non-invasive anatomical and functional roadmap that provides information that is similar to that as if the patient has actually undergone an invasive procedure with 3-vessel physiology. Yet this information, of course, is provided before in the calm, cool environment of a lecture room or of a case discussion room, allowing the interventionalist the opportunity to really interrogate the patient-specific anatomy and physiology, to go to the cath lab with a potential plan that can help inform revascularization, I would think, in a fashion that's at least thoughtful and hopefully will lead to more complete revascularization by understanding what the interventionalist is going to find at the time of the cath. Here's an example, severe LAD disease. You may say just cath the patient. The problem was there was a moderate to severe right coronary lesion. Instead of just cathing the patient, you can see that the physiology is severely abnormal in the LAD, and yet it's normal in the right coronary. Instead of going just based on anatomy, I've now provided my interventional colleague a roadmap saying LAD is severely abnormal, the right is not abnormal, the patient needs a stent in the LAD or needs to be considered for revascularization in the LAD, and the right coronary should be left alone. And here's the corresponding FFR, which was negative in the right coronary. So why do I think that this will be an increasingly important tool in this concept of non-invasive anatomy and physiology? Well, the AHAIACC updated their data elements just this April. And so now if I send a patient in Canada, because our databases mimic these, if I send a patient with anatomy and physiology and the physiology is positive, my interventional colleagues can now appropriately revascularize the patient solely on the basis of this non-invasive data. The presence of stenosis and the presence of abnormal physiology meets the criteria for inclusion in the NCDR cath PCI registry and is aligned with the appropriate use criteria. So I think a powerful step forward for this concept of anatomy and physiology non-invasively from CT to enable not only the diagnosis of coronary disease, but help guide revascularization of said disease. So I'll close there. I think the future of cardiac CT is bright. I just touched upon some elements really around the diagnosis of coronary disease, as well as the potential role of non-invasive physiology and very loosely around atherosclerosis. But obviously there's a whole other spectrum of the use of cardiac CT as it relates to, mitral valve disease and tricuspid valve disease and structural heart disease. But I look forward to working with all of you in learning together about how we can use this tool to better guide management of our patients with a whole host of cardiac conditions. Thank you again for the opportunity.
Great. Thank you, Jonathon, so much. That was an exceptional and incredibly comprehensive and informative talk. And thank you again for being so accommodating and getting up so early, as it's 3 hours earlier there in your time in Vancouver right now. I think we can take some questions.
Jonathon, it's Eric Velasquez. I also want to thanks for getting up so early and for such a wonderful talk. I guess the question I have for you is a little bit of a softball, but I think it's just kind of maybe to help me. So a lot of the work, which is increasingly impressive, positioning CTA and particularly functional CTA in the kind of pathway or roadmap to planning interventions has been based on normal, relatively normal patients, patients with relatively normal LV function. Can you speak to how different groups of patients, particularly those who might be at higher risk due to LV dysfunction, whether this information applies to them or what we have to get what information we need to get to that point?
No, it's a very important question. I mean, I think what we're seeing is that, and it's a very important one, and that's where I think image quality is so important, Eric, because, I go to many sites and they say, I can get away with a higher heart rate because I have a dual source CT. And what I've realized in my practice in the last decade is the patients we're imaging are very different now, than we were a decade ago. A decade ago, we'd often do these very, very low risk patients. And now we've seen, the integration of, we do scans for patients with troponin elevation, obviously not high risk and STEMI, but many of those patients were doing it with, for 70-year-old diabetics and smokers. And so in those patients, the real key to have good anatomical yield to me is a very low heart rate, appropriate use of nitrates, and appropriate scan protocols, optimizing the contrast and optimizing the scan radiation parameters to ensure that there's modest noise. And I think if we do a really good job and we're really purposeful on that, we can manage almost every patient. I think that there's obviously still some challenges. Obviously, the extremes of calcium, patients with renal failure, with extreme, where we can't give contrast, obviously that's a clear one. But even those with severe calcium can be challenging. But I think beyond a few of those, I think it really lies in the image quality and the data acquisition. And one of the challenges I've seen in the U.S. is this vicious cycle because reimbursement is so poor, volumes have been modest, and then access to the scanner for dedicated cardiac purposes has been a challenge. And so it's this vicious cycle of, not doing as much, and then the quality isn't what it needs to be, and then the diagnostic yield isn't as good as it should be. So, I really think that once we get that class 1 indication, and it can be used in complement, more routinely within cardiology and radiology, and have larger volumes and then pathways set up, it can be operationalized such it can be effective for the vast majority of patients.
Hi, Lauren. It's Ed, or Jonathan. Thank you for that nice talk. It's Ed Miller. I had a question about the data on using the point estimate of 0.8 in the new appropriateness for revascularization guidelines. I mean, I think you rightfully stressed that the FFRct number is a continuum, and there's some error in that estimate that is fairly substantial. So how did we get from a use of an FFRct to avoid cath to now a quality metric that has at least a 0.122 standard deviation error in it to guide revascularization?
Yeah, so no, I think that's a really good point. And so when we look at the reproducibility of FFRct, it's been studied, modestly. There have been a couple of papers. Sarah Gower published one from Denmark and a couple of others. And the coefficient of variation is about 0.03 as compared to invasive FFR, where it's about 0.015. So the reproducibility of FFRct is obviously, it's inferior to invasive physiology, but only marginally. I think the issue of the binary cut point is a really, really important one. And, I didn't provide that guidance, and I agree with you. I don't practice like that at all, right? I mean, I think that when you're in that gray zone, as you mentioned, we know from invasive physiology that the event rates are fairly modest, between 0.75 and 0.83. We saw that recently from FAME, and we saw that also from the 3-vessel Friends study recently. And actually what added value there was the translesional gradient. I don't know if you saw the data from Quantifying and AHAIACC, but the morphology of plaque on CT helped inform risk, in that gray zone. So I think that's the practice of medicine. I think the issue, as you know, when it comes to these data variables, is that they have limited ability to provide that sort of granularity, which I think is a shame, and it's a concern for me for the reasons you described, because I think it could lead to suboptimal practice. How do I use it in our practice? If it's what I always say is, if we send a patient to the cath lab for a moderate to high grade LAD lesion, and the non-invasive physiology is below 0.74, and the anatomy looks concordant, with the non-invasive anatomy, not precise, not adjudication of the exact, but it doesn't look like there's a potential error, because of course there's errors, right? I mean, there are cases that we don't get it right using non-invasive data, but assuming the anatomy looks similar and the physiology is strongly positive, they will just go and revascularize. But if it's in the point above 0.74, between 0.74 and 0.8, and the symptoms are significant enough that we've elected to cath the patient because of an apparent anatomical target, they will often adjudicate the physiology invasively for the reasons you described. And similarly, if it's immediately above that 0.8 threshold. So I think it's important. The practice of medicine can't be that binary.
Do we have any other questions from anyone?
Hi, Lauren. There are a couple of questions on the chat.
The first question, I think, was answered. The question was about beam hardening artifact impact on the result of FFRct. And I don't know if Jonathon wants to comment on that specifically, but I think he had said that having sort of a lot of calcium, which could lead to that type of artifact, may be an issue in severely calcified lesions. And that might be something you can comment on further. And now we have a question from David Herr, who again thanked you for a very comprehensive review, and is wondering if you can make any comments about the potential added value of incorporation of contrast CT perfusion, and how that may continue to evolve and improve along with the anatomical information and physiological information from FFRct.
Great. Yeah, no, excellent questions. I think that the beam hardening and the partial volume averaging and the issues related to calcium are obviously really significant in the present time. I always say that the key is, as you know, is that heart rate control will help manage some of that, because you can't add motion to calcium, otherwise you're really going to have a problem. And the other thing that we've done, we really moved towards lower tube energy scanning fairly routinely based on body habitus and chest circumference. Now, if the technologists see any calcium on a scout, they use 120 kVp because it's just too challenging at lower energies to image patients with calcium. With regards to CT perfusion, I think it's another important area for exploration. It's not a tool that really makes a lot of sense to me, in our healthcare system, because it's very labor intensive. The only way it could make sense to me is if it was available, if I could do a stress only study and get accurate anatomical information and perfusion data, I guess that would help. But right now, to diagnose coronary disease and then bring the patient back to do a radiation, another exposure of radiation, another exposure of contrast, and do a stress in a system where we also ration by availability and access is just too challenging. So I don't know. It's not been something that we've done that much of clinically beyond research. So I think that time will tell, though. But I think we need to see how it would possibly fit in, particularly given the fact that I think global perfusion studies are going to face challenges with regards to adding beyond anatomy, given the results of ischemia that maybe they're not incremental to the anatomy with regards to determining who needs a conservative versus a upfront revascularization approach.
Right. Thank you for that. I actually have a question, if you don't mind. Love to hear your thoughts on the use of coronary CTA, specifically in patients who may be younger, but with a very significant, true history of early coronary disease. And as everybody knows, these patients are often not captured in the appropriate risk category based on traditional risk factors. And these are people who may have significant coronary disease. It may be non-calcified plaque that wouldn't be picked up with a screening calcium score. And obviously that doesn't fit into the current, appropriate use criteria for truly asymptomatic patients. But there may be some utility in identifying earlier and even high risk plaque in those patients. And so what signal, has been seen in the studies that have been done, and what type of study do you think we would need to do to show that there may be value in that specific patient population?
Yeah, I think that's such a good question. I mean, as you know very, very well, the issue from all the data to date and with the confirmed registry, I mean, we've not found any population amongst asymptomatics where CTA was incremental to calcium scoring, even at 5.7 years with regards to risk in the asymptomatics, except for diabetics, interestingly. I think we all know that if you have a patient with a strong genetic predisposition, high-risk patients, we see many patients of South Asian ethnicity in Vancouver who have strong family histories. And for those patients, I think there may be value of CTA because obviously if you're waiting for calcium, you're not going to see much calcium in a 30-year-old. But if you see atherosclerosis in a 30-year-old, it's obviously premature and would be important to know. Many would argue, well, you should just treat those patients aggressively anyway. So it's a challenge. As you probably know, David Newby, again, is showing real leadership and is randomizing patients between in Scott Hart 2 in an asymptomatic population between traditional care and CTA. It's remarkable to me that it was able to do that. That'll be obviously incredibly important as it relates to helping answer that additional question. So I guess we'll wait to see those results. I don't think that there's going to be anything better than that coming out, but that'll be incredibly helpful to help us understand how to use CTA in that population, if at all.
Great, thank you. And looks like we have one last question here, asking if you could please comment on the assumption of blood being a Newtonian fluid. It's their understanding that blood is non-Newtonian at most shear rates.
Yeah, well, you've got the wrong dude, unfortunately, to answer that. That's above my pay grade. I think for that question, there's obviously CFD experts that could help answer that question. I would be happy to take that to Charlie Taylor, who's from Stanford originally and is the engineering mind behind FFRct, and or to my colleagues also at the UBC. But that's a good question. My understanding is that is applicable in as it relates to coronary flow, but and there's plenty of evidence and data to support that. But I'm obviously not going to be able to get into a deep discussion with someone who clearly has got an engineering background.
Yeah. Great. And do we have any questions from anyone else? Great. I have actually one last quick question for you because you did bring it up as well. So with the lots of radiation reduction techniques that we are utilizing, you mentioned that sometimes you'll do a scout film first, and if there's calcium, for example, in a more obese patient, you may up the KVP on that case. We don't do a scout film, to check for calcium other than just the planning, quick, axial slice.
Right.
Do you think that in certain weight categories, we should be potentially increasing our radiation dose and using less radiation reduction technique than we usually do if we think that the case is going to need FFRct?
Yeah, I mean, it's not just FFR, to be honest with you, Lauren. I mean, I think obviously that's relevant, but as we move, I always say, like, when if you send me a 40-year-old woman with atypical symptoms, or a 30-year-old woman, I could do it with almost no radiation, right? It's not a problem. But, we've just seen such a shift as we move to CT first strategy, doing 25, 30 a day. The burden of disease has just gone up so much. And so I think that obviously we still need to always practice according to ALERA, but as I remind my fellows that, that if we do a non-diagnostic CT at a low dose, it was certainly not aligned with ALERA, right? Because the patient needs another test. So, again, we don't want to overdose patients, but you have a 67-year-old man with symptoms. I think we really want to be accurate above all. And so even on that single slice for planning, I think you can still often see calcium. And if you do, I think I would definitely lean towards 120 kbp. And to me, the most important, and it's interesting, our median heart rate is around 56 beats. 82% of our patients, almost 85, have heart rates below 60 at the time of scan. So to me, that's just the key, right? And then a good scanner.
Great. Well, thanks again so much. I think that was all the questions.
Yeah, thank you for the honor. It was a privilege to be able to speak to you this morning. Thank you.
You too as well. Stay safe, everyone.
Yeah, stay.
All right, take care.
Thank you, Jonathan.